A very good morning to you. How you're doing? Welcome to Your World. It's a beautiful Wednesday morning. My name is Mikali Mary, and on Your World, if it's on Wednesday, then you know it's all about health and wellness, and today is no different. Today we dive into the world of lupus, and it's called the great imitator. Why is it called so? And why do many lupus patients go without proper diagnosis for a long time? Most of the times they look like they're okay. See a team to tell like, oh, you only come. So we're getting into all of that today to just understand what is the lifestyle, what are the symptoms looking like. Do we have the proper medication available for them? Do even the awareness of it? How readily available is that? And the question that we're asking you today is pretty simple as well. We are asking you the question of the Philip, if I could just have it as well on the screen. The question of the day. There we go. We have the question. Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? And how did you handle it? How did you handle it? That's the question that we're asking you today. Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? And how did you handle it? NTV Kenya on all of our social media platforms. Please do indulge us. Our WhatsApp line is also open. And if you have any questions whatsoever on today's conversation, please feel free to send that on our WhatsApp or social media. And introducing our panelists today, starting from my immediate left, Winnie, I miss you. Starting from my immediate left, we have Faith Mohammed, who's here to share her story with us. She's a lupus warrior. Karibu sana, lovely to have you on the show. Right next to Faith, we have Dr. Eugene Kalman, who's a physician and rheumatologist. I hope I said that right. Your R inaweza change kwa kitu ingine if they're all in the same sentence. Thank you so much for coming. And last but not least, we have Dr. Sheila Archeng, who's a rheumatologist as well. Karibu sana.
Thank you.
And maybe we just start with the basic of what lupus is and why it's called the great imitator. And we can start with the doctors first, and then we'll get the lived experience after we understand what that is. Dr. Eugene or Sheila? Doesn't matter. Ladies first.
Right. So lupus is what we call an autoimmune disease, which means it's a disease that attacks the immune system. Now, your immune system is there to protect you from things like infections. But in lupus, the body does not recognize its own cells and starts to attack them. And that's why it's called an autoimmune disease. We call it the great imitator because it can present like many other conditions. It can present like infections. And in our setting, tuberculosis is one of the major mimics of lupus. It can present like viral infections and lots of other infections that we see. And it can sometimes make it very difficult to challenge this in clinical practice, diagnose this in clinical practice because of that challenge of mimicking several other conditions. So you have to have a high index of suspicion of lupus to begin with.
Okay. And just to clarify that, is it different kinds of conditions in the same person? So we treat this and then it becomes something else? Or is it just there's one condition that probably will have with one person? Dr. Eugene?
Not exactly.
Yes.
The example I give is like James Bond.
Okay.
Because James Bond of the 70s, 80s is the same person.
Yes.
The fancy gadgets and everything, but the face is different. So if you look at the science of lupus, there are different pathways in the immune system that cause the symptoms. So the symptoms can be very varied. It's like a hydra. So patient one might have something different. Patient two, they have some common background symptoms, but maybe one patient may be more of kidney problems, another patient may be more of skin, another patient may be pregnancy loss, and maybe unexplained blood clots. So that's why it's like she was saying, it's an imitator. Because the presentation can be very, very varied.
Okay, okay. That means also how we diagnose, we have to be open-minded to just look at where probably it's all coming from. Faith, having lived this experience, maybe from the onset, what was it like for you before probably a diagnosis was done for you to know exactly what it is that you're battling? How was it? At what age did you start experiencing the symptoms?
Looking back, I got my diagnosis back in 2023, which is 3 years ago.
Yes.
But looking back, I've had the symptoms since I was in secondary school.
Oh.
So I have had a mixture of everything. But the one that was very persistent was migraines. I had migraines for a very long time.
that were unexplained. So I used to see a neurologist, and he would try to tell me everything you feel. Like, when do you get the headache? Do you get it when you're standing in the sun? Do you get it when you're seated, when you have your earphones on, when you're in class and you can't focus? So when I look back from secondary school, it's when my symptoms started to be more pronounced. I've had the unexplained blood clots, consistent migraines. I've had gastrointestinal issues. I also had a lot of skin issues. Like, I used to get very red rashes, eczema. Sometimes I'd feel my skin is so tight and they would not be able to explain like what was it. And so when I used to see a doctor, I would wonder, because they would say you'll get eczema as a child, but then I felt like I got it when I was way older. And it did make sense. But what led now to my diagnosis was the unexplained blood clots, which now the doctor had to dig deeper. Then I was able to get a diagnosis.
What would happen this many times that you'd go to hospital? This means different medications for the different things.
Yes.
And even when you go back to hospital, it's presenting as something else. It's a red rashes this time.
Yes.
It's a headache. It's a blood clot here. So for
for every symptom, I would just get a different specialist to manage what I'm feeling. If today I'm feeling the headache, they'll refer me to a neurologist. If tomorrow my eyes are so dry, they'll tell me go see an ophthalmologist for it. Yeah. Tomorrow I have the skin rash, they'll give me some ointment or some cream to try and manage. They'll tell me I have allergies.
Yeah.
So it was just a cycle of seeing doctors here and there. I remember I used to be so sick and I would think something, especially when you're in high school and you can't stay in class and your mom is thinking, hautaki kusoma.
Yeah, they would do that.
Yes. Then tomorrow, last week I was there for a skin rash. Tomorrow I can't stand my stomach. I have nausea. My stomach is too painful. So I go get treated for H. pylori, but still the symptoms don't go away. So it's just, they would manage the symptoms, but not get to the root cause of the problem.
Yes. That's a long time. I think high school to getting your diagnosis in 2023. Is it normal for one to go through that much time before they get a proper diagnosis when it comes to lupus?
So because, like we said, it can mimic anything, it can be very difficult to pinpoint what the actual problem is. Like she said, she presented with several systems, the skin, the stomach, so it can be quite difficult. And I think one of the challenges we face in settings where we have a limited number of specialists in rheumatology is that by the time you get to see a rheumatologist, you've suffered with this condition for many, many years. So you meet physicians or just general practitioners who might not have seen lupus before. So it's, even for an experienced physician like a rheumatologist, I must say, it can sometimes be difficult to pin down that diagnosis. So even more challenging for somebody who's never managed or met a lupus patient before. So a lot of patients we see in our setting do struggle with this for a long time before they actually get the diagnosis clinched down. But I must say that we are working on a lupus registry in Kenya, and looking at the data from our registry, we are seeing that the time to diagnosis is getting shorter with time as we get more specialists in this field and more awareness about lupus among Kenyan clinicians.
Okay. Yeah. I think the question would be then, when 2023, what happened? Were you sent to somebody different? How did they now pin it to lupus?
So I felt sick. I started getting unexplained swelling. And by then I was still in Mombasa. So the person who could manage me at the time was a physician.
Okay.
So I saw a physician who did a panel of tests. Among those tests, an ANA became positive, an ANA. It's one of the primary tests for testing for lupus. So when it came positive, it automatically led him to tell me that this is a rheumatological issue. So I started looking for a rheumatologist. But at the time, I couldn't get one in Mombasa. There was one who used to come, but he'd come once a month by the name Prof. Omondi Oyo. Okay. So I had to come all the way to Nairobi to have him look at me.
Okay. And now the kind of treatment that you get from the diagnosis is totally different. Mm-hmm. But when we look at probably, so we said autoimmune, we said it's your body fighting your body, and there's nothing much you can do. But what some of the other causes, are there other causes that probably, if it's not maybe born with it, how else can we acquire this?
So in terms of science, to be honest, we don't know the cause.
Okay.
That's number one. But number two, we feel
that is so scary.
I know. We know the science that happens after it starts, but the cause has not been identified.
Yes.
But we feel it's multifactorial. Many things coming together. So there's a role of genetics, but people say nobody has it in the family. We can't for sure.
That's
Isn't
true.
it? Yeah. People say environmental factors, why are you amongst many other people? But we feel that probably there might be an issue with the X chromosome, and that's why it's more in ladies. So one of the genes supposed to inactivate these particular illnesses is more in ladies, because women is XY and XX, so you have more probability to get the disease. But on top of that, there's really a trigger, the trigger that we don't know. We have people have said maybe viral infections can do that. I know sometimes you get referrals by people who got COVID and now they're thinking maybe they have it or not. But to be honest, we don't know what actually causes that. If you look at even the signs of the disease, that's why you'll find even the diagnosis takes a lot of time, because sometimes we find how a patient presents on week 1 vis-a-vis a year later is very different. And that's why you find somebody who goes to India and say, oh, the doctors in Kenya are fake and all that. But it's just that the disease was just in what? In evolution.
Yeah. And
probably just at the end is when you get the diagnosis. But also with lupus, it's more this clinical, isn't it? So I think just to know what to look for. There's a paper we had done a few years ago, Professor Oyo. We found that the time
to that's the same Professor Oyo?
Yes. Okay. He was my teacher. So we found that time to diagnose is about 13 years. That's a long time. 3 to 13 years, that's a long time. That's a long time. Yeah. But what we found in that particular paper was that most commonly, I think it's what to look out for. Joint pains was very common there. Skin, like this eczema. Yeah. I know it's a bit hard these days with sunscreen, but it's more of a heat rash. Get itchiness and everything. Sometimes, but I know the current ladies, everybody's on sunscreen, so it becomes a bit difficult to tell that, yes. Apart from that, blood issues, this gives an explained low blood, just unexplained, wondering, okay, what's going on here? You go to the hospital, I think it's a viral infection, or I explained anemias, low blood, low platelets. So from the research, we found that if you had joint pain, fever, the skin, and the blood, most likely you could have what? Lupus. The only challenge with what Sheila said is that particular presentation can also be infection. Yeah. Yes. It can be malaria. Yes. It can be typhoid. You get. Yes. So that's where the diagnosis is a bit hard. So it actually requires very keen history taking from the doctor. But sometimes also it may need a few months before you get the full diagnosis.
Okay. And it takes, say, for example, when you talk about the 13 years, for every ailment I come with, I get treatment for it and I go back home.
Yes.
And then I turn out to be this sickly person who's always going to hospital to get And when you talk about the test that was done, Faith, that now they were able to do, what did you call it? Anna.
Anti-nuclear factor.
Okay, that one. Yes. Can it be done earlier, or it has to be done at a certain age when now, a certain time when you've gone through everything else that we need to go through for that to be done?
It's tricky because we don't treat blood tests, unfortunately. So a positive ANA does not mean you have the disease, because ANA can be positive in autoimmune illnesses, arthritis, scleroderma, anything. And so it can just be positive and mean absolutely what? Nothing. Okay. And the challenge with the ANA is that over time, our cutoffs have actually dipped. Like my time I was in medical school, for a positive ANA was 320. Yeah. Then I went for masters, it came to 160. Now it's about 100. So you can see we are trying to get guys a bit earlier. Even the diagnosis criteria actually change over time. But it shouldn't be that you do the ANA before, because if you do ANA before, it'll just be mass hysteria. ANA, and the labs will love it because they make a lot of money. And that test is actually very expensive. Yeah. I don't know how much they charge, but it's around 3,000 to 5,000 shillings, which is not would be reachable for most clients. So I think at the end of the day is that the test should fit the symptoms. So don't just do a blind ANA test, then you come back wondering, because also an ANA test does not mean you have what? The disease.
Yeah. Okay. Do you want to add on to that?
Yeah, so just to reiterate that in a patient without lupus symptoms, if you check an ANA, you're opening Pandora's box, because now the patient will think I have lupus. But in the context of somebody who had very clear symptoms like she had, as long as your index of suspicion is high at that point and you can get the symptoms, you've clarified the symptoms of lupus, you do the ANA at that point, that's confirmatory, along with another panel of tests, which we'll discuss.
Okay, great. And we'll do that probably after the break, and also to understand what treatment looks like and how available it is in the country currently. And you mentioned price. I'd like to also get in there and find out, now that we've gone through a couple of years of just trying to figure out what is wrong. So now we have found out, what does it look like? How available is the treatment and how affordable is that? And do you have to travel to certain clinics, because that's where you can only get that done? And if that's the case, what can we do then to just make sure that they are readily available for all Kenyans? And just going back to the question that we have for you today before we go on a break, the question we're asking you today is pretty straightforward. Have you ever felt sick or not okay? People didn't take it seriously because you looked fine. And how did you handle it? Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? And how did you handle it? And TV Kenya on all of our social media platforms. Our WhatsApp line is also open. If you have any questions whatsoever, we are willing and ready to answer them for you. Well, not me, you know, the experts who are here, okay? Don't go too far. We'll be right back after the break. Welcome back to Your World. It's Health and Wellness Wednesday, and we're talking about lupus today. And the conversation is about understanding the signs, the symptoms, management, availability of treatment, all of that. What do we have to do when it comes to our lifestyle? We'll get into that in just a bit. But the question that we're asking you is, have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? And how did you handle it? Have you ever felt sick or not okay? Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine? And how did you handle it? That's the question we're asking you. NTV Kenya on all of our social media platforms. And our WhatsApp line is also open. We're taking all your questions, comments. You can share your story as well with us. And we will be looking at that as the show continues. So, Faith, you've shared your story up until the point now you know what it is.
Yes.
They have tested, and now we have a diagnosis.
Yes.
Many years later.
Many years later.
What does the journey look like for you from there? Because now you probably have to see a specialist to be able to walk the journey with you.
Yes.
And even how you're taking all of this emotionally. Because it's like you're back in and out of hospital quite a bit, but now you've gotten a name for whatever this is.
Yes. It has been challenging since their diagnosis. I used to get frequently, more admitted frequently since the diagnosis. But when I got on medication, especially the first few years, it used to be tough. I actually felt when I got the diagnosis is when I felt more sick.
Oh, you felt more sick?
Yes.
Okay.
It's like now everything erupted.
Okay.
But now when the treatment kicked in and settled, I have been very stable, especially since last year, August. Up to now, I've not been admitted, which is a plus for me.
Yes.
Because one of my fears used to be, now I have to see the doctor, and I used to never know if I'll come back home or I'll end up being admitted for something. So yes, I see my doctor very frequently. The first few years, I'd see him monthly. There was a time I used to see him 2 weeks, and then monthly. Yeah. Then it became monthly. So now I can go for 2 months, and then I go and see him 2 months, something like that. So it's easier. But medication is monthly. It's daily, not monthly. Medication is daily. What are you doing?
Okay.
Medication is daily without fail.
Okay.
So yeah, that has been the challenging part.
So what is the importance, or why the frequency at the beginning to see the doctor 2 weeks? Now it's slowed down a bit, but what is the importance of, 2 weeks you're here, 2 weeks again, 2 weeks, then we go spreading it out?
So, like in Faith's case, she presented quite late to us. And by that time, we see that as the disease has gone uncontrolled for years and years, you develop other systems involved, and you develop sometimes damage in several organs.
What do you mean systems involved?
The body system. So like she had skin disease, some patients end up developing kidney disease, others develop complications with the heart. So by the time we see you, when the diagnosis is delayed, in many cases, you'll have had multiple different organs in the body involved. And the disease will be active, what we call high disease severity. And now controlling the inflammation at that point becomes a little bit of a challenge, because we have to start you on high doses of medications to control things quickly and then taper them down. So you need to come and see us very frequently to make sure that we're getting on top of the disease, you're taking the treatment as required, you're not developing side effects from the treatment, and that the disease is going into what we call remission, that it's starting to get quiet. And once we get into remission, then we can now extend the follow-up periods to maybe 6 months or 12 months, depending on how the lupus is.
Okay.
Just to add on that also, the main medicines take so long to work. Take like 2 to 3 months. And usually, that is really our challenge with the patients. The patients want an instant instant
I mean, I've been
response.
struggling and now I know what it is. And you're now giving me fresh batch new medication. It needs to work now. Okay, but that's not the case.
That's not the case. We have, treatment is in two parts. So we have, like for her in high disease activity, we first have to put out the fire like she said, and put out the fire with steroids most of the time. And the steroids you have to taper or reduce every 2-3 days. So you have to monitor her response. How is she doing? So tests, regular reviews and all that. As you wait for the third month to do what? To take her off and continue the normal medicines. But in between you still have to take the normal medicines. Yes. So that is the challenge we have with Lupus. And there's also like, the follow-up is good because usually also that particular period, they have so many questions. So many questions. Some of those questions cannot be answered in one sitting. Because and then one of the challenges they have with Lupus, they get brain fog, so they forget stuff a lot. So they'll remember this, next remember that thing. So sometimes it's a bit hard to talk about the phone and say, okay, just do this. So you have to actually come and listen at the doctor.
Okay. Faith, had you heard of this condition before, and now that you have been given this term, this label that probably you carry for a bit in your life, did you have enough material in terms of information? Was it readily available for you to just dive deeper? I mean, it was a relationship between you and your doctor. Nizo Maswali's and Dr. Eugene is talking about that you just keep shooting and shooting and shooting until you understood it.
No, I'd not heard or I didn't know much about it before. So when I got it, it's when I became more curious about it. And the first time I got my diagnosis, my rheumatologist sent a psychologist to see me. I was still in the ward. So she came in the morning, and then I was wondering, how serious is it that they had to send a psychologist?
They take care of you in all shape and form. I like that.
Because he felt I was just so sad about it. So he decided to send a psychologist to see me. So when she came, and then she told me, did Doc talk to you about it? Then I was like, yeah. But then I was wondering, why did she have to come? But like, is it this bad? And then she said, it's going to be a tough journey, but you'll be fine. So I was wondering, how tough is it? Like, is it just not like any other normal disease that can be managed? But now staying in it for a few years, I understood the journey. And the challenge is also not so many people, like other chronic illnesses, not so many people have it. So I also had to find my people. People who can relate exactly to what I feel. So when I got the diagnosis now, I started searching. I'd go on Instagram, I'd look what support communities are doing out there. When I Googled, they'd send me links to different types of lupus forums, lupus communities. So now, the more I dug, the more I found out more about it and who I can lean on. Because even just depending on your family, yes, they're very supportive, but it's also very scary for them because now umekuwa mgonjwa. Even when you tell them, now I'm feeling like this, they feel so sad. They're so alarmed. Yes, do you need to go to the hospital right now? Everything now becomes, you've set off an alarm. But when you talk to a fellow lupus warrior or a lupus patient, they'll be like, been there, done that, you'll be fine. Or don't worry, you can do this and this. So when you're in a support community, it's easier to understand more and even what people are going through.
Okay. And when you're walking this journey, you mentioned earlier that you were in Mombasa. Is this where you're going to get the treatment, or you have to outsource, go elsewhere?
I never got the treatment in Mombasa. Even getting medication in Mombasa was a challenge for me. Like the daily medication that I used, just walking into a pharmacy was not easy. They'll tell me, we don't have it, but we can order for you in 2 days or things like that. So for me, I always had to come back to Nairobi for me to get the right medication on time, to see my rheumatologist on time, and even just to get lab works done on time. Everything is more easier here than it is there. And even just getting, now, after I got into now the lupus community, I understood now that there are 2 doctors there. There's Dr. Sophia and Prof who used to come once a month. So even booking Prof was a challenge because then you would call Mombasa Hospital, I'd like to book for a rheumatology clinic to see Prof. On they'll tell you the clinic is full for 2 months. This is now, we're like in August, so you need to see him. Maybe next is available, we can book you for October. So then you cannot wait until October. So I always had to come back to see him. So it was always a constant journey of traveling and things like that.
This is the actual case on ground.
And just to add what she says, like, one of the challenges the patients will tell you is that, it's an invisible disease. It's not like a broken leg, you can see.
Yes.
And one of the most troubling symptoms, apart from the brain fog, is fatigue.
Yes.
And it's a pendulum. Today you're okay, tomorrow you're off, so people get actually tired. And that support actually declines.
Yeah,
so,
because I mean, you look fine.
That's the thing. That's the thing.
That's
That's the thing.
But the case of having to travel and availability of treatment from wherever it is that we are, and it looking like you'd think Mombasa would be, you know.
I know again, but we're slowly improving. I know we're not many, to be honest, but we're slowly improving. We have Sophia in Mombasa. Eldoret, there's Dr. Ganda. Kisumu, there's Dr. Omondi, Charles. And Nairobi, where most people are, but we're slowly doing what improving. But also one thing which we're really trying to target are the undergraduate training and the postgraduate training. So that at least, and we actually have a rheumatology clinic at Kenyatta, so we have at least more numbers and we're able to teach our students better. So they're able to pick people up earlier. What they can manage, they do some sort of first aid. When they're stuck, actually they're scholars. Then we're able to sort them out. But in terms of the medicine, it's a challenge. And she'll probably tell you, maybe she'll tell you later about the cost and about part of the issues, because in terms of business sense, if I'm getting a drug that is maybe 200,000 and only have one patient, I'm not going to stock it in my pharmacy. You get what I'm saying? So the costs are also what also prohibit, and the numbers also. But slowly, I like what she's done with the registry. I think it's long overdue. The registry, we're able now capture all the patients, and at least with that one, we're able to present some sort of data to the government. You can say, look, we have this number of people. Yeah. Can you do something to help us?
I think let's get in there. Let's get into the registry and what it actually looks like and what we're doing with this information and data that we're collecting.
So a registry is simply a database of patients with a particular condition, and we follow the map over a period of time to track their outcomes, understand the burden of the illness that we are seeing and complications that come with it. So in partnership with Professor Oyo, the University of Liverpool and Cambridge, we started working on this registry in 2024. And currently we have approximately almost 500 patients. We've been able to collect very, very enriched data on the disease, the type of disease that we're seeing in terms of which organs are involved. Is it the kidneys? Is it the heart? Is it the brain? And we're also able to collect data about the medications that patients are using. Infections is one of our main serious outcomes, because patients with lupus, there are medications that suppress the immune system, and infections can occur as a result of that. And a lot of other data about the quality of life and how lupus impacts these patients on a day-to-day basis. So it has really been important for us to be able to quantify the problem. So we've been seeing it as clinicians in clinical practice, but now we can actually quantify the issue. And with that information, we've prepared a proposal that we submitted to SHA along with the patient groups to try and ask SHA to integrate rheumatic diseases, not just lupus alone, but other rheumatic diseases into their NCD, non-communicable disease package, to be able to give financial protection to our patients so they don't have to struggle to buy medications, struggle to get access to care and all that. And then just to cover the point that she mentioned about limited access to specialists and clinics being fully booked up, there is also a rheumatology postgraduate program that is in development at the Mater Hospital with the stewardship of, again, Professor Oyo, who's one of the pioneers of rheumatology in the country. So that is imminently being launched. So hopefully we can train more specialists within Kenya and deploy them in areas of high need. One of the things our registry shows is that patients travel from far and wide. And just in clinic, we see patients from as far as Uganda, as far as Ethiopia. So it's not just a problem that's unique to Kenya. Yes. It's a problem which is in many parts of Africa. Yeah. So we can quantify this problem with that data from the registry.
Is this the first time we're doing the registry in this country?
Yes.
Congratulations, guys. I think it's a big deal. Yeah. It's not an easy journey to have walked to where you have, and even being here and sharing your story, and to have this in place. That means whoever comes in next will find an easier, better system for them to get help. Let's talk money then. Let's talk how probably expensive it's been, or how much it cost for you to now get this medication. And I know we felt like it's going to be now we know what it is, we are dealing with it. But then how, in terms of medication, how has that been?
Lupus is very expensive. And also, unfortunately, for most lupus patients, you get patients who have just lupus, but then there are patients who are also coupled lupus with something else. Like it would be lupus with rheumatoid arthritis, lupus with Sjogren's syndrome. Like me, I'm lupus with Sjogren's syndrome.
Okay.
So approximately, for me, a month medication would look like I'd say 25 to 38,000 monthly. And on top of it, I have other things like tests, which now add on to that burden. There are even months where maybe if I get something big, like I told doc my lymph nodes are swollen, I've been complaining about them for the past 3 months or what, maybe want to do a procedure which could still add on to that. So it's very expensive to manage lupus.
Is it covered? Do we have insurance? You mentioned SHA in conversations to see how that goes, but
it's covered but very limited.
Okay.
Because then even you'd get some insurances would give you an outpatient for 100,000. We would deplete that in 2 months.
Yeah.
And it's not that I'm misusing it.
No.
Yeah. It's just that that's how my medication looks like. So for those who are lucky enough, you'd get people to maybe help supplement for you to get medication. But just sustaining for you to be healthy alone is very expensive. It requires a lot of financial support. And for you to also do the right thing, that is get your medication monthly, follow up on your labs and things like that, because that is the right procedure for following up for the disease. But generally just, because now you don't also take one medication, you take a couple of medications to be able to sustain it. So yeah, financially, it's actually a big financial burden.
It's ridiculous to imagine that only, I don't know what percentage of people in this country can actually afford that. To even get to know what it is might take longer, if at all. And when you find out, then it's even a heavier burden to try and get. What happens if if I'm not able to take care of myself this way in terms of medicine? Hata kuna mitishamba lifestyle yangu nifanye nini nayo, because it's pretty expensive. An average of maybe, just call it maybe 20,000 every month.
Actually, we can estimate the figures based on, there's a tablet we use called mycophenolate, which we use quite often for patients with severe lupus. One tablet costs 90 Kenya shillings. One tablet.
500 mg.
500 mg, and we need 4 tablets ideally, optimal dose for the patient. So in a day, you're spending 360 Kenya shillings. In a month, you're spending 10,000. Yes. And this is one medication. You have lots of other medications to buy along with this. So the cost can easily exceed 50, 100,000. And the outpatient caps for insurance, they don't cater to that. It's just, it's unaffordable for very many. And often we end up, they end up on suboptimal doses of medication, and we then have to fall back on more widely available medications like corticosteroids, so they're steroid tablets, which we know also come with the burden of increasing diabetes, increasing hypertension. So it becomes a vicious cycle.
When we talk about government hospitals and how they're supposed to be affordable, and she's already shaking her head. This one's for don't go there. But if with government assistance, this should be probably more affordable. If they were part of it at all, are they? Is there something that probably they're doing to subsidize?
I think we just need data.
That's where it starts.
That's where it starts.
So the burden is on your shoulders, Dr. Sheila.
Yes, so we have submitted the proposal to SHA.
Okay.
And there are some medications that we can access under SHA, although it's inconsistent. So high-cost advanced therapies that we require for very severe lupus, so one drug called rituximab. But across the globe, there are lots of other medications available for patients with severe lupus who don't respond to standard tablets. But we don't have access to those. If you don't have private health insurance, you can't afford the medication. So we're really trying to push this agenda forward to enable SHA to provide coverage for our patients in terms of not just medication access, even blood tests for follow-up, diagnostics access. So I think we didn't touch on the fact that diagnosing lupus, we have the anti-nuclear antibody test, but we also have the extended nuclear antibody panel. We have things called complements.
Break it down.
These are specific tests that we check in the autoimmune system to try and see if the patient just has lupus or other overlapping conditions like Faith has said. Because with lupus, it's autoimmune conditions are a family of diseases. And sometimes you get more than one condition, so 2 overlapping conditions. So the panels help us to understand if there's another risk of developing another condition later on, if you already have that condition. And it can easily exceed 40,000 Kenya shillings, easily at diagnosis, which is not affordable to many Kenyans. So it's a real problem.
It is a big problem, and I don't know. Yes.
And just what you see, the tests guide us on what we can tell the patient to predict going into the future, but also choice of medicine.
Yeah.
So sometimes we're not able to give what would be the most appropriate because we don't have all the tests that are available. And the test like the ANA she's talking about is about 20K. That's just one. That's minus ANA, complement, and the rest, and the rest, and the rest. So it's very expensive. And then also on top of that, she's saying that actually some insurance actually decline.
They say no from the outset. I mean, they'll make you do the tests before they even sign you up.
They say that it will not cover you. That's what they say.
You're a risk.
You're a risk, high-risk patient.
Yeah.
And then now the challenging part is that you look at most of the lupus patients are young, supposed to be working. So apart from that now, they can't work because they're unwell, they can't afford because they're vicious now. Cycle over and over and over and over.
In terms of the way we live our lives, and I'm imagining we're managed. Are we curing it? I mean, this is management for life. Is this it?
Unfortunately, for now, this is it. You just manage it for life. There's no cure.
There is no.
There's a technical cure. It's still
I
early,
like emphasis on technical. Okay. Please tell us about that.
Technical. There's a therapy called CAR T-cell therapy. Basically, they take some of your immune cells, put something in it, then they go and attacks the lupus cells. So from the preliminary data, it's very promising. The only challenge is cost. Try and give a guess. Try and give a wild guess.
Go with yeah, get somebody 20K more. Two less, I double to 40.
Not even close. Not even close.
No.
Not even close.
Are we going to get to 100?
Not even close.
Okay, then we can't afford it as a country to get. I mean,
it's almost 60, 70 million. I know. But it's promising. You see, like she'll even tell you that for them to have found a cure for lupus, no other autoimmune are not that bad. But for them to find a cure for lupus is a very big deal. For us, because lupus is so complex.
Yeah.
Like how patients are all different. It's so complex. So the fact that what something that can work is very promising. But the only challenge is that it's not for every patient.
Yeah.
It's a criteria for that particular drug. But there's hope.
Okay.
Right now, there's better diagnostics. Medicines are a bit more available. Our patients are living longer now, isn't it? What I tell my patients is that you are the Gen Alpha, the first generation.
Yes.
So you're going to suffer. Just accept discrimination and everything.
Yeah.
But with time, the second and third generation will get it a bit easier. So just hang in there.
Yeah.
Just hang in there. There's lots of hope.
I'm hopeful and you're here sharing this story with us. But if it's something that I will manage for all my life before we get to 60, 70 million accessibility, what about lifestyle? What does that look like? How do I live my life? What changes do I have to, input in my life to just make sure that even as I'm getting medication, I'm also complementing that with my lifestyle?
One thing I noticed with lupus, the culprit is inflammation.
Okay.
So first of all, diet.
Okay.
Anything that causes inflammation has to go, be it the sugars, be it the carbs. You really have to control, or if you can do without it, the better. Yes, so anything that can trigger or increase inflammation, that has to go. Most of the time they'd say exercise helps, but one of the things we struggle in is joint pains. Fatigue. Tomorrow you walk 1 kilometer, you're sleeping for a whole week just to recover from that. Also, we can't walk under the sun because the sun is also a trigger for flares for lupus. So that has become a challenge. But of course, the more you move, the better for you, which also comes with its consequences, or should I say, utalipia badai in simpler terms. Yeah, but that also helps with that. And then they also say stress triggers flares.
I'm already stressed by having
Now imagine us.
Yes.
Oh, Lord.
Yes, so anything that is a stress factor for you must go. There's no two way around it. So you try to minimize anything that could cause any kind of flare. So that is stress. Diet plays a bigger role for it. And then now, if we can incorporate exercise then, that is good, though it's not easier for every warrior.
Okay.
Yeah.
It feels impossible. Like there's no winning.
No, imagine it's not that bad, imagine.
Yeah.
It's all about just what I've learned is education. If you educate the person well, they know the cause of the triggers and they take their medicine. Most of them are very cheeky, they don't take their medicine. It's annoying because, for them, they're taking medicine, but they're still getting flare-ups.
Yes.
So it can be very frustrating on their side. And when Africa, there's also the mganga who has come from a relative and said, this can also work.
Yeah.
So we don't know about that. But it's all about just education. Yeah. And telling the patients that, I tell them it's like a pendulum. You'll have ups and downs, but at some point things will do what?
They will align.
Yes.
Is the triggers the same for everybody? It's different for every singular patient?
It's difficult. Like stress. Why stress is annoying for us because how do you measure stress? How do you tell this is 10%, this is 30%? You get...
It's stress. They need at 10.
And then I'm telling the patient that don't be stressed. And they have no pass. Of course they're under stress.
It's impossible, but we'll get to just understand a bit more on that. And the question that we're asking you today is quite direct. If you've ever felt... have you ever felt sick or not okay, but people didn't take you seriously because you looked fine? How did you handle it? And we have a bit of feedback on WhatsApp, so let's take a quick look at WhatsApp. So the question is, hi, please ask the panelists to say something about clots in the lungs caused by lupus. That is Alphonse. Thank you so much for that. Hello, it's Hannes from Kisumu, logging in, show Ukohot. Laura, yesterday you did it well, thank you. Okay. Good morning, Wikali and the panelist. Wikali, 2 years, my blood pressure was 230/210, which led to stroke. I think God of doctors of Jaramogi Oginga Odinga Teaching Referral Hospital, Kisumu, who have stood with me through this journey, not forgetting my physiotherapy doctor, Dr. Lame Kotieno of Jaramogi Odinga, my siblings and relatives who have never bothered with my sickness. Wacha tu nasikia kulia. So sorry. Emotional support, family support. What is the difference between lupus and lupus anticoagulant? What is the best medication for a patient who is lupus anticoagulant positive? My name is Masi. We'll have your questions answered after the break. Let's see the next question. Lupus is real. This was not until my daughter was referred to Dr. Oyo and Dr. Acheng. Question, what are some of the health insurances that can help in the treatment? Otherwise, good work from Dr. Acheng. My daughter Melody is coping very well. Patrick from Kakamega. Thank you for that. It all started one evening with tummy upset, then diarrhea. It felt it was a bit unusual because I never had that kind of stomachache. I just took some antibiotics and assumed I was fine after getting relief. Let me tell you mine now. It came back after a week and it was severe. No one could believe I had abdominal pain and diarrhea because I looked okay. I went to hospital only to realize I'd been infected by amoeba. I would advise that no matter how okay you look or feel with some relief, please see a professional for examination. Someone else would never know how bad the situation could be. That is true. And the cost is something else. My name is Alfine. Yeah, Alfine. Thank you for that. As a lupus warrior, I just want to take a moment to commend you for continuing to push awareness out there. It truly means a lot because many people don't realize how long, confusing, and sometimes frustrating the journey to diagnosis can be. Your voice is helping so many feel seen and understood. Let's scroll down. I would like to express my sincere gratitude to my doctor, Dr. Eugene Kalman, for making my journey much easier since my diagnosis. Having a supportive and understanding doctor makes all the difference, and I'm really thankful for the care, patience, and guidance he has given me along the way. Please kindly pass my heartfelt thanks to him. His support has not only helped me medically, but also given me comfort and confidence as I navigate life as a lupus warrior. I truly appreciate him. Caroline Mugambi. Is there a registry for other autoimmune conditions like Can you guys see that?
Ankylosing spondylitis.
Elsie Nandra will have your question answered as well. Okay. Let's read this one before we go on a break. Hello, I'm Joseph Wright Odhiambo. On the question of the day, yes, I have definitely felt sick or not okay, but people didn't take it seriously because I looked fine on the outside. I've learned to handle it, but quietly taking care of myself, even if others didn't recognize what I was going through. Sometimes, let's scroll up. Sometimes it's all about trusting your Philip. Okay, thank you. Sometimes it's all about trusting your own feelings and not letting the external expectations of others affect your well-being. Asante sana for that. And we'll have the questions answered after the break, so don't go too far. We'll be right back. Welcome back. Health and Wellness Wednesday. On Your World, we're talking about lupus, coping with it. What is it? How does it show up? How does it manifest? What's the treatment like? We've gotten to how much it costs, guys. It's not cheap. It's heartbreaking. And I've got a bit of questions which will help answer some of the questions that I had for myself as well. And I had asked just before the break. But very important questions have come in. There's one that says, what's the difference between lupus and lupus anticoagulant? What is the best medication for a patient who is lupus anticoagulant positive? That is Mercy.
So I usually get that question a lot. The lupus anticoagulant is a test.
It's a test?
It's a test.
Okay.
It looks for something called antiphospholipid syndrome, which usually presents with unexplained blood clots.
Okay.
And pregnancy losses, usually in the first 3 months. Lupus on its own is just a disease. I know that the tests have similar names, but it's a test. And that's what? Lupus. That's the difference.
Okay.
Though, interesting enough, you can have lupus patient with a positive lupus anticoagulant test. They, like what Sheila had said about the overlaps, because they're all autoimmune, antiphospholipid and the lupus.
Okay.
Yes.
Still, I think, on lupus and clots. Ask the panelists to say something about clots in the lungs caused by lupus. This is Alphonse.
So with the clots in the lung, so one of the, I remember the time when we were in medical school, when we get a clot, how we were taught is that get one clot, we used to look for the usual causes, contraceptions, long travel, isn't it, cancers and all that. And then until we didn't find a cause, we treat for 3 months, the end. That's what we used to be told. If it recurs, you treat now for life. But when you look back now in retrospect, it was the wrong doctrine at that particular time. And any unexplained clot, look for at least something autoimmune in somewhere in the background, because it's very unfortunate when you find somebody gets like 2-3 clots and nobody has thought about lupus or even antiphospholipid system or just something autoimmune. So I think the take-home is that any clot you find, whether it's in the leg, tummy, the lung, think about what? Autoimmune. And autoimmune most likely lupus or the antiphospholipid syndrome. And sometimes what happens is that I've seen a few patients who get a clot maybe 10 years ago.
Yeah.
Nobody knew what to make of it. Now 10 years later, you get all the symptoms for the what? The lupus. So we really have to keep monitoring those particular patients. Okay. In terms of treatment, you must treat the underlying autoimmune disease that is there. But now the blood thinners way is a bit different. So for example, we have options like there's a drug called warfarin. We have some newer drugs that are in the market now. We call them DOACs. They are newer. The only challenge with the DOACs is that the evidence in autoimmune is a bit on the lower side. Okay. So they push more for old school, which is what? Warfarin. But warfarin has its challenges, because warfarin you can't eat skuma wiki. There's a lot of lifestyle changes that comes with it, but also frequent monitoring. So most people tend to shy away from those ones and try the new ones. But the evidence is very small, so it has to go as per patient. So for the doctor should be able to classify the patient and say, are you high risk or what? Low risk. If you're high risk, there's no debate. It's warfarin. If you're low risk, we have drugs like rivaroxaban that you could try. But ideally, all patients should be on warfarin. But it's case by case.
Okay. I think you'll help us with this one, Faith, to even from your own personal experience. She says, Lupus, this is Patrick from Kakamega. Lupus is real. It was not until my daughter was referred to Dr. Oyo and Dr. Chieng. Question is, which are some of the health insurances that can help in the treatment? Otherwise, good work from Dr. Chieng. My daughter Melody is coping well. This is Patrick from Kakamega. So in terms of insurance, have you found one that works? And how is your experience with that?
Jubilee has worked well for me.
Yes.
But the premiums are quite high. I was previously on AAR. AAR also works, but the capitation is also high.
Okay.
From our group, people say Heritage also works. I've not had an experience with Heritage, but some of our warriors are also on Heritage. So the top three, which I know, is Heritage, Jubilee, and AAR. AAR and Jubilee from my experience.
Okay.
Yeah.
Okay. Any other that you might know of that they can...
It's a difficult one. Usually the insurance companies, what they do is they profile you.
Yes.
Depending on how many organs are involved, is it newly diagnosed. And sometimes they might put caps like you can pay insurance for the first year, but you can't claim.
Use it, yeah.
And then what they do is they're very cheeky. You might find an insurance for 10 million, and they say for chronic cover is 1 million. You get, that's how they catch you.
Yeah. Okay.
You get or 2 million chronic cover, what, 100,000 or 200,000. And then that's outpatient drugs, and say, oh, it's over.
It's over.
You plan yourself.
And the sad thing is that these are conditions that can largely be managed in outpatient settings. They're not conditions we need to keep admitting patients to hospital for. So when you impose caps of like 200,000 on the outpatient cover for 12 months, it doesn't really help the patient because we can't do the follow-up tests, follow-up visits. It just becomes, and the medications alone can easily max out that cover.
Okay. Is there a registry for other autoimmune conditions like inflammation of the spine? Now that you've taught me that is what it means if I'm not able to say spondylitis. Elsie, forgive me. But yes, Dr. Sheila.
Unfortunately, we don't have other registries yet for any other rheumatic diseases in Kenya. So ankylosing spondylitis is a condition that affects the spine. You get inflammation in the bones along the spine. Along with things like rheumatoid arthritis, we don't have registries for those yet. But the hope is that we can build on that work in the coming years and start to get other registries for other conditions, because having this information is really helpful, not just for quantifying the disease burden, but also for policy planning to be able to improve our health systems to cover these diseases.
Okay, so currently no, but work in progress. Probably will have that done. When we were talking about, before we went on a break, we were talking about, management and lifestyle and all of that. But if you could just sum up, and I think I just asked if it's the same for different people and if it's different for them. But if we talk about the probably top 3 things that as a lupus warrior you need to do to be able to manage the condition better.
I think number 1 is seeing your doctor regularly. That's number 1. And being honest about taking medicine, because the most common causes of flare-ups are just not taking medicine. That's number 1. And I liked what she said about the high disease activity. The longer you have high disease activity, damage is a lot. Or patients abuse steroids. Steroids will cause damage to the body. In this part of the world, the sun is a problem. The example I give, I hope I'm political, is a vampire. Think about it, because lupus is not a what? Russia, like the vampires. So we tell them wear preferably sunscreen. And the funny thing in the guidelines, they say you should apply every 2 hours, which is not practical. I've been forced to Google price of, I don't know sunscreen, but I'm forced to Google. Some are 6,000, 7,000. So it's not, and it's a very small one. So things that help, if you're able to get like sun protected clothing, some of the clothes have UV light in it, that can at least limit your cost on buying the sunscreen. And number 2, exercise is normally a big fight in the clinic. They'll tell you, I'm tired, I'm in pain. But the problem with lupus is that in the beginning, what disturbs a lot is the control. Infections, too many drugs, up and down in the hospital. When you get that stable point, now the long-term effect come. Now you get a bit of weight, there's hypertension, there's diabetes. And if you able to start the exercise early, you're able to prevent those particular complications. One very common question is diet. Diet is a bit controversial. And the thing is that lupus is not a lifestyle disease. That's what people should understand. Lifestyle is gout, alcohol, nyamachoma, that and we know, isn't it?
Yes.
But lupus is not a lifestyle disease. It's a disease of the immune system. Yes, the diets help and everything, but it should not be the only thing that you manage your lupus with. Because a lot of patients will tell you, oh, they come and debate and say, can I eat healthy and all? Everybody eats healthy, but where do you have the lupus, not somebody else? And the thing about diet also is tricky because what works for one may not work for the other. We all built genetically different. Like for me, the example I give myself, my family are taking the genes from my mom's side. So my mom said we are the bigger ones.
Yes.
My brothers are getting genes from my father said the slim ones, and they eat everything and they never add.
Anyway, you need to smell chocolate, and that's it.
That's it. And about the stress is hard because ideally they say avoid stress, which is not practical. And one thing which helps is counseling. One thing which I appreciated for my fellowship was the role of mental health. We take that thing for granted. In Africa, for some reason, we think if you mention counseling to anybody, I'm now mad, I don't know what. And actually, it's more about how to cope with that particular illness. Because if you have mental issues, there's a lot of depression, a lot of anxiety, you will not sleep well, you develop other issues. Some call fibromyalgia, which is another headache. You had other top of the lupus. So the mental part is something we tend to ignore, especially in this part of the world. And it's something which I encourage my patients, but they're very, very hesitant because they think, oh, I'm now mad, you don't take me seriously. People, the fact, the assumption that you don't take me seriously. You think that I'm making up what? Symptoms. But the thing is just how to cope with the illness going. They will profit it for you. How to cope with illness going what?
Forward, yes. And everything that is added on top of this is just expensive because the
specialist psychologist.
There's just a bit, but there's a question that was asked earlier. It was a comment. It was more of a comment of how people around this particular person were not very supportive. Because they do not look unwell, there was no support. So sometimes you'll find you keep quiet when you're feeling bad because you don't want to share that or burden them or be made to feel like you're in your head and all of that. And also touch on the importance of counseling as you walk this journey for anyone who's tuned in, and importance of even family support.
Family support is more important, I think, because we are a lot around family.
Yeah.
So as we look very well. Even me, when I tell someone I'm sick right now, I have fatigue, it would be like, no, we pack a lipstick. Like, you don't look sick at all. Yes. But yes, family support is very essential in this journey, because even when you're in like a household, there are things you can't do. Like me, I don't do house chores. If I wash dishes, there's nothing else I can do. Yes, I'm just tired, and I'm genuinely just tired. It's not that I'm pretending.
Are you able to work?
Yeah, I'm able. It's a struggle, but now I have to do it. Yeah. The fatigue really kicks in, but I manage. I thank God for that.
And is it your business? You employed?
I'm employed.
So the employer has to understand your condition and be okay with that, and still give you an opportunity.
Yes, and even when I'm I'm really thankful for my employer. My employer has been supportive even when I'm away and when I'm sick. I've not really had to go through those hardships of explaining myself, or I've had to be there because there's no one else. I've been really covered well at work. So I'm really grateful for that. Yes, and also at home, I really get a lot of support. If it is in terms, if I need help, they tell me, just say you need help. If we need to post, just say it. So family support is really essential. And also just having a community around you who understand what you're going through, and they can support you in different ways. That's very important. Be it be friends, be it be supporters from like our support groups, things like that. So you have to surround yourself with people who, and also being vocal, like telling people, I'm not okay. I say we have to advocate for ourselves. You have to say you're not okay. You have to speak out also for people to understand. I know it can be tiresome, especially for people who are normally very independent, to say I'm sick, or you tell someone you're sick today, tomorrow you don't want to say you're sick, but unfortunately we have to speak up, and we also have just to say our truth, so that also someone can know how to support you.
Okay, the role of counseling and therapy.
Okay, personally for me, when someone tells me about therapy, I feel like you have pulled the big guns out. Now I'm like,
you are those ones.
Yeah, I'm those ones for sure.
You're who you. Yes, Faith. Why does it feel that way for you?
because then you go to a psychologist or a therapist,
yes,
and you have to sit down and they'll ask you, how are you feeling? Like, tell me, how are you feeling? And I'm like, what am I supposed to? It sucks. And I already know it sucks. I don't want to keep talking about it, and I don't want to be pitied because, okay, they'll tell you this, but yeah, I just want to, they help you understand the reality of it. It is needed. That part I get.
Yes.
But I understand that the situation is hard. But yes, we do need to see therapists. Personally, I really struggle with it because then I'll feel like at a neuromia, and then I don't want to be asked how I feel. So yeah, for me, therapy is a struggle.
Yes.
Even that day after Prof told me I see the therapist,
yes,
and I was meant to see her on outpatient, and she called and sent reminders.
On live TV, and be a Prof Aukufanya.
And he followed up to know, did you go to see her? And then I told him, Prof, I didn't go to see her, but I know what I'm doing. He's like, no, you don't know. He tells me, it's okay to be helped. Just accept someone to help you. It's okay. Yes. So yeah, for me, it's a struggle, but I do know it's needed for that one.
And I think it's really important.
From UK, Sheila.
Yes. Dr. Sheila, please. So I think it's really important at diagnosis. Why we push for it is so that you can, one, understand the disease and acceptance. You can only manage yourself well if you accept the condition that has been diagnosed. And that involves adherence to medications, following up with your doctor at regular appointments, even coping with stress, anxiety. And a lot of lupus patients get issues with mental health, stress, depression, anxiety because of the impact of that diagnosis on you. So seeing a psychotherapist helps us manage all those other conditions that come along with it and prevent flares. Yeah.
I'm not feeling I'm convinced.
I'm stressed.
You're stressed.
I'd also like to understand, probably with the registry and the proposals that have been given, government, SHA, and all of that, what is the bigger picture? What do we anticipate to see? What are we hopeful for if it goes through, it's adopted, and how it trickles down to Faith and the others who probably really need this help? But before we get to that, let's just take a look at WhatsApp. We have a bit of feedback there and questions based on the conversation that we're having today. Thank you very much. Hello, Mikali and the panelist. My name is Atieno. My sister was diagnosed with lupus SLE in September last year. This is her situation as at March 2026. In my assessment, she's just getting worse. She's constantly in hospital. How do we help her? Can we have contacts for the rheumatologist? Is there one in Homa Bay? Currently, she is being seen by a dermatologist. We are desperate. Okay, so we'll get an answer to that. Hello, what should I include in my diet, please? Recommend at least 3 to 5 items. Is this program being recorded? I would like to share it with some friends. Yes, it is. You can find it on YouTube and Facebook and YouTube. You can get all that information there. Do we have another one? I was diagnosed with lupus by Dr. Eugene in 2023 and have been on the same medication since, as I cannot afford a follow-up visit. Earlier this year, my symptoms worsened with severe inflammation, pain, and fatigue. I visited Mater Hospital, where Dr. Oyo recommended lab tests costing 42,000 Kenya shillings, which I cannot afford. Since February, I've been unable to do the tests and I've continued the same medication, but my condition ain't improving. Can this bring about more complication if the tests are not done earlier than recommended? Okay, we'll answer that as well. If lupus coagulant is a test, does it mean if you are lupus anticoagulant positive, you have lupus? That is Mercy. So maybe we can just pick it up for that last one from Mercy. I think it's a continuation from what was asked earlier about the anticoagulant positive. Does it mean if you are lupus anticoagulant positive, you have lupus?
It's not necessarily. Because the lupus anticoagulant looks at something called antiphospholipid syndrome. I know the names are similar, but it's something a bit different.
Totally different.
Lupus. Yes.
Okay. Marcy, I hope that answers your question. But if you still have more questions on this, please feel free. We'll have Daktari answer that for you. Diagnosed with lupus by Dr. Eugene in 2023. I've been on the same medication. I've not been able to get more tests done. I went to Mata, 42,000 shillings. I can't afford that. The situation is not improving. And the question is, can this bring about more complications if tests are not done earlier than recommended?
So that is a good question, and I think it's a challenge to us as rheumatologists. I think it's high time we have like, you see, like HIV, we should borrow a leaf from HIV. There's a paper we are writing where we're trying to ask for a call for local Africa guidelines. Because you see, like HIV, we see how HIV is managed here and vis-a-vis outside is a bit different, but we have a bare minimum. So I think for us in Africa, I think it's time for us to have like a bare minimum. And from the bare minimum, we can be able to get like a bare minimum of drugs and then move from there. Because for 2,000 is a lot, and not many people can afford in this particular economy. So it's a challenge to just come up with a simpler, something more local in terms of guidelines on how to diagnose and also how to do what, how to manage.
But the question of will this make it worse for them because they're still on the same medication? That's what they can afford. What does that mean then for them?
For them. So, you see, like if you look at lupus, we look at the treatment that is available. We have old school ones that are still there and they're a bit cheaper.
Okay.
You get, so it's not what we give now, but sometimes, you know, you have to make the treatment according to the patient.
Yeah.
Because when in Kenya, the patient is come to the consultation room, you have to do something. So there are options that are available. It's just for her to reach out and be able to see how we can help out.
Okay.
But also, diabetes are done Kenyatta. You can get assistance there. Drugs are a bit cheaper.
Aha, okay. KNH.
I know that the waiting lines and everything can be a bit demoralizing. Like for me, I know. Like for me, when there's a patient that's in the clinic pro bono, I don't even charge them. I just come and tell them what to do, and that is it. So I think it depends how open you are with the rheumatologist. We're not bad people, Betty.
No, I don't think so. I don't think so.
And if you come and tell me I can't afford this, we say, okay, you can afford this, let's try this other option. It's not as good as this one, but it's an option that we can try to pursue.
There must be a lot of pressure as well for the doctors that are handling this because Mko Kidogo, and there was a question about Homa Bay as well. Let me see if we have that. Hello, Wikali and the panelists. My name is Atieno from Atieno. My sister was diagnosed with lupus SLE in September last year. Her situation is at March 2026. My assessment, she's just getting worse. She's constantly in hospital. How do we help her? Can we have contacts of the rheumatologist in the building? Is there one in Homa Bay? Currently, she's being seen by a dermatologist.
So this is one of the key areas that we're trying to address through our SHARP proposal. At present, we have 13 rheumatologists in Kenya.
13?
13 for a population of 50 million. But we're one of the better performing countries in Africa.
Oh, yeah?
Our neighboring countries some don't even have a single rheumatologist, and we're seeing patients coming from other countries. Now, the global benchmark for estimated rheumatologists per 100,000 individuals is 4 for every 100,000 Kenyans. Other countries don't have that globally. Maybe they have 1 or 2, but our figure translates to 1 for every 4 million. And out of the 13 rheumatologists we have, you'll find them at level 6 facilities, so the teaching and referral hospitals, Kenyatta, Joe TRH, that sort. But from level 5 county hospitals downwards, we don't have anyone. And then the problem is majority of them are also within the urban centers. So Kisumu, Nairobi, Mombasa, Eldoret. So patients have to travel far and wide to seek this care. So for the patient in Homa Bay, there is a rheumatologist in Kisumu who she can see, Dr. Charles Omondi, at either Joe TRH or Kanika. So if she can reach out for his contacts, we can share them and she can see him.
Okay. And you can share contacts as well? Yeah, okay, good. So the part where they're seeing a dermatologist, what does that mean if we need to understand? Because is that probably how it's manifesting?
Because it has different ways of manifesting.
Yeah, so it could be the skin.
Yes.
Could be the skin.
But lupus is not a one-man show. It's multidisciplinary. So I think that one, derma is okay, but at least I think a physician might not be a bad idea also. But like I said, she said Charles is available. It's in Kisumu. I think Homa Bay Kisumu is about a 2 hours drive. You should be able to get there.
Okay.
Yes.
Okay. What should I include in my diet? Please recommend at least 3 to 5 items. Is this program being recorded? Would you like to share? I'd like to share it with some friends. You can find it on YouTube, on Facebook. You can share it from all those platforms. 3 to 5 items. This is someone who probably has a struggle. I just need 3 to 5. I will stick to those ones. Just point me in the right direction, Faith.
For me, my top is I take calcium supplements, but I also supplement with things that would boost my calcium levels, which is drinking soup.
Yes.
Things like that. So I would boil chicken bones, those kind of things to get calcium supplements from that. Fruits. I make sure at least I have 1 fruit a day. If it is true, the apple keeps the doctor away. Yeah, so I do take fruits. I'm very big on also vegetables. Yeah, those are my top 3. Okay. And then now, of course, the supplements, the vitamin D and calcium are my main supplements. I take them. Calcium I take every day. Vitamin D I take on alternate. Or I take a combo that has both calcium and vitamin D.
I think this can work even for you. This diet is something I'm going to take as well.
Yes.
for self. So I think that works.
Yes, it works.
In terms
work.
of But I don't know, Philippa, do you want to add something?
Maybe just usually for autoimmune diets generally, we have ways of looking at it, either inflammatory, anti-inflammatory. Though the contribution is very small, and I don't be quoted, it contributes a small proportion. It's not the major thing there, isn't it? So foods that have vitamin E, vitamin C are very anti-inflammatory. The fruits, the vegetables are okay. Junk food is what we want to try because a lot of unsaturated fats and blah, 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 blah. Apart from that also, a lot of the patients with lupus also have nutritional deficiencies. They don't go to the sun, so vitamin D needs to be somewhere there. The drugs that they have, the lupus that has calcium, there's a problem there. People who are on drugs like methotrexate that interferes with the folic acid and vitamin B12 and all that, maybe more vegetables that are there. Apart from that also, we need to be aware that certain drugs will cause a lot of nausea, vomiting, so it's about adjusting when you take the medicine. So for example, things like methotrexate and mycophenolate, you won't take on a day when you don't have a lot of stuff in your tummy, because they can cause a lot of vomiting and everything, and then the patient will feel like, oh, I'm not doing well. Actually, it's methotrexate, mycophenolate, and azothioprine. So at the end of the day, it's tailor-made. So each patient has got their own that works for them. And the last thing is, remember that we were saying that our patients will get more hypertension, more diabetes, overweight. So healthy either way works. Yes.
Okay. We'll get back to just answer more questions and also find out, because there's hope and a lot of things are being done behind the scenes, what do they look like exactly if we do? So we're going to go on a quick break. We'll be right back. Don't go too far. Here we go. Welcome back. This conversation is continuing. We're over here wondering where's the place for herbal medication in all of this, but we'll see. We'll see where it goes. We're talking about lupus today on Health and Wellness Wednesday on Your World. I'm your host, Mwikali, and there was a question that I'd asked earlier, Dr. Sheila, about there's a lot of work that is happening behind the scenes with the education bit of things. There's a registry up, there's communications with SHA, government is involved in one way or another. What does it look like if these things go through? What is the hope there?
So there are several angles to this.
Yes.
The first is better access to care specialists, number one. So through the rheumatology training programs, we have more specialists available. Patients don't have to travel far and wide to get the care. And time to diagnosis is significantly shortened because they see a rheumatologist much earlier. Yeah? And we can deploy rheumatologists within the various tiers of facilities from level 6 all the way down. At least you can have access to rheumatologists within your locality. The second issue is access to diagnostics. Yeah? So if we integrate these into SHA packages whereby they cater for the cost of doing some of these tests, for example, the anti-nuclear antibodies, and maybe partner with private companies, because if you look at the ENA panel, they're not available in government facilities. They're only found in private facilities. To find a way to integrate this within the SHA benefits package so that the SHA actually pays for these tests for us to initially diagnose the patient. And following on from that, they then give us access to medications. So I know Dr. Eugene mentioned that Kenyatta usually has very much lower prices for some of our medications, which is good, but then the issue is that the supply is inconsistent. Yes. So consistently patients come and say the medication is out of stock. Yes. This is the cheapest facility where I can buy the drug. What do I do? Yeah. So ensure that these medications are stocked within these facilities, and consistently accessible at an affordable price, or you integrate that price within the SHA package, So we're asking for things like the basic drugs we use, methotrexate, mycophenolate, azathioprine, hydroxychloroquine, one of the cornerstone drugs we use in lupus, and then access to the more advanced biologic therapies. So those are some of the things we're asking for, and we need to not forget the children, because children are a very priority group in this. So provide these packages for adults and provide the same package for children.
What does it look like? How far are we from probably getting feedback, if positive, negative, just feedback?
I mean, we've just submitted the proposal, but this is something that is very actionable. If we look at patients with cancer, with HIV, cancer is a non-communicable disease. Somehow they're integrated within SHA, they're getting benefits, they're getting affordable care, they're getting access to therapies. So we're not far off. We just need ARD, rheumatic diseases, to be recognized as an important component of non-communicable diseases. And what I can say is the fact that we normally look at lupus or rheumatoid arthritis through a single lens, not appreciating the fact that these conditions often occur alongside other major non-communicable diseases. So about 30 to 60% of our lupus patients will have hypertension. Hypertension is a major non-communicable disease, Our sustainable development goals are fighting towards reducing the incidence and deaths from hypertension, from cancer, from diabetes. But these are conditions that we face in lupus. Patients with lupus have these diseases concurrently with the lupus. So we need to address this as a component of the larger group of non-communicable diseases. And I think once we're not far off, there are solutions in place. We just need to start having sustained discussions around policies and actioning and translating this into practice, so we can action these recommendations and come up with these packages.
Okay. You mentioned communities. When you got your diagnosis, you found a community of people that you could talk to. And there was a comment about using your voice and how it's encouraging and all of that. Yes. In what spaces do you create awareness of this condition, talking about lupus, and creating awareness, and for people who probably do not know what it is that is happening to them, to just make sure that we all are aware. If I go with this information home and I see something happening or someone is feeling unwell, how to handle them and all of that. So how are you using probably your voice? And being here is one of them for sure. Yes. But how are you using your voice, Faith?
We also have our main group, which is the Lupus Foundation of Africa, where we have different warriors from different parts of Africa, but Kenya being our main, or should I say our mother home, where most warriors come from.
Yes.
You can also find us on Facebook, Instagram, and on TikTok. You can just send a message and we send you a link to join. So there, not only do we have lupus warriors, we also have caregivers, caregivers who want to be there on behalf of their sick patients or parents or family members, and also different people who support us at different capacities. Like we also have someone from insurances who advises us if we have challenges. We have someone from the medical community who we also partner with to be able to advise us on a thing or two. And Dr. Sheila we always put her number there. If you have an issue, reach out to Dr. Sheila. So there we use our voice to reach out to more people, and it's also easier because then we are able to communicate. I'm feeling this way, what can I do? They post a picture, we are able to comment and just be able to support each other. I also talk about lupus on my platforms, even for people who don't understand, on Instagram, on my WhatsApp, on TikTok. I talk about different things that constitute about lupus and the challenge we go through, so that even from a layman's perspective, someone can know how can I help. And even when someone sees something, they tell me, I have someone who feels this way and this way, what would you advise? So I'm able to guide them if they need to see a doctor, or in which specialty they can see someone for whatever they're feeling. And also if they know someone who has lupus and they'd like to reach out. And I do get friends who tell me, I also know a friend who has lupus and they don't know who they can talk to. So can I share your contact? And I'm usually open to be able to support and just to advise and people just to help each other through the process. We also have different communities among us. We also have one of the communities called Thrive Community.
Okay. It's
also a good upcoming community for the lupus. So we are all joining together to speak in one voice because at the end of the day, we are fighting lupus. So there are different platforms. Anyone, if you'd like, you can reach. Mainly being the Lupus Foundation of Africa and the Thrive Community.
Okay. Yeah. What would you say, especially for early diagnosis or newly diagnosed patients, what is the thing that probably they struggle with the most? And it could be probably on your end as well, but you probably have seen it as a trend. When you find you're talking to a new person has been, directed to you, what are some of the things that you've seen that this is consistent, a thing that they struggle with when they get the diagnosis?
I feel like one thing we do struggle in our community, it's like everyone, when they get the diagnosis and you start medication, then you get more symptoms that erupt. So you'll see someone said, I started medication, but now I have skin lesions, or I have developed now hyperacidity and other diseases that come along the way. And then most people wonder, have you made it? Does it get better along the way? And I want to reassure them that it does get better along the way with the right support. And also just following the advices our doctors are giving us, because that's the best way forward. And also self-awareness.
Yes.
To be able to understand your body and even the things that you feel like, this is where I struggle. Like for me, when I started, I had lupus only. Along the journey, I learned I had Sjogren's syndrome. I became hypertensive. So you get a mixture of everything, but once you get a hold of it, it sure does get better along the way.
In understanding and even living and adjusting your lifestyle.
And adjusting your lifestyle, yes. It does get better.
There's a question that came through on my WhatsApp about sleep, and I don't know the significance of that. I'll just read it in a bit. But the question that we're asking you today is, have you ever felt sick or not okay, but people did take it seriously because you looked fine, and how did you handle it? Have you ever felt sick or not okay, but people didn't take it seriously because you looked fine, and how did you handle it? NTV Kenya on all of our social media platforms. On WhatsApp, we have a bit of feedback and questions probably that we can have our panelists answer. Yes, so Mercy has more questions. Mercy says, I am lupus anticoagulant positive. I take blood thinners daily. Clopulate, to be precise. Is this okay? So we'll have that one answered as well. Thank you, Mercy, for listening to us and sending more questions. Is there a relationship between rheumatoid arthritis and lupus? I have lived with arthritis for more than 30 years on medication and later developed hypertension. I am scared of developing the same. I'm 60 years now. Rosaline Mukabana. Okay, thank you for sharing that, Rosaline. We are a patient support community. This is what we were talking about right now. The Thrive community, made by patients, for patients, in brackets warriors, caregivers, supporters, and specialists. We would like to welcome all warriors and everyone who would like to learn more about lupus and other autoimmune conditions to join us on the World Lupus Day this coming month. Okay, so we have a date with you guys.
Yes.
Thank you so much, Thrive, for getting in touch with us on that. Okay. So we have a question from Mercy. I think she continues to just find out. What does this mean? She's been taking blood thinners daily, clopulate to be precise. Is this okay for her?
It's a tricky one. I think it's best answered if we know the context of the full diagnosis. So that may be tricky to answer on air.
Okay.
And may be tricky to answer on air that way.
Okay. Okay.
Because usually we have different categories, and I wouldn't want to say it's a wrong one or a right one.
Yes.
You must put in the full context of the patient.
I think this is where we give Mercy your number. Mercy has plenty of questions that are fair enough. They need to be answered. So if you feel comfortable to share, so you can just share your number.
0723 596 189.
Say that again.
0723 596 189.
Dr. Sheila?
0113 786 116.
One more.
0113-786-116.
Absolutely. Marcy, this is for you. This is for you, so that you get direct, so that they don't give a general answer to your question, because they need to understand what the history looks like and what the situation is looking like at the moment. Is there a relationship between rheumatoid arthritis and lupus? I have lived with arthritis for more than 30 years on medication and later developed hypertension. I'm scared of developing the same. I'm 60 years now. This is Rosalyn Mkabana.
So I think we touched on this earlier.
Yeah.
When I explained the concept of a shared family of autoimmune diseases.
Yes.
When you have one, there's a possibility of developing another. Yeah, so she potentially has an overlap. So she already has lupus, did you say?
She
has rheumatoid.
Yes.
And hypertension.
And hypertension.
Yes.
Okay, it's not guaranteed that she'll develop lupus.
Yes.
In some patients, they do develop several conditions. In some patients, we just have the one condition for life. What we'd advise is that she monitors her symptoms. If she noticed a change in her symptoms or developed sudden new symptoms on top of what she normally has with the arthritis, then at that point speak to her rheumatologist so we can establish if some other complication has developed or she's developed another disease.
Okay. She mentions she's 60 years old. Is there a thing about age with autoimmune diseases? Is there a correlation at all? If there is, maybe we can just...
So there's a correlation. So most of our patients are seen the childbearing age group. So once you get to menopause, the numbers actually go down tremendously. So the chances of getting lupus after menopause is actually lower vis-a-vis before menopause.
Rosalyn uko sawa.
Chances are very slim.
Tupatie hope hapo hivyo. I think the other one was from the Thrive community, just talking about World Lupus Day coming up next month. I don't know if there are any activities that are planned for World Lupus Day.
Yes, we have World Lupus Day next month on 9th of May. Is World Lupus Day. The theme this year is Steps for Change.
Okay.
So over the years, we've partnered with Aga Khan Hospital. We're really thankful for their partnership and support. So we'll be at Aga Khan Hospital for the World Lupus Day. We'll do a bit of a walk to go with the theme for Steps for Change. So we're inviting all warriors, all caregivers, all supporters. Na wale watu wako na nguvu ya kutembea.
Yes.
Because the warriors can't do much walking, to be able to join us, for us to make an impactful day for the World Lupus Day. We'll also be we've invited some of the doctors for patients to be able to share a bit of their journey. Those who need consultation here and there, they can be seen. There'll also be some free checkups that we'll be having: blood pressure check, sugar check, urinalysis. So yeah, we'll pick it from there. A bit of health checkup, talks here and there, and then a walk for the World Lupus Day. So we invite everyone on 9th of May at Aga Khan University for the World Lupus Day celebration.
Would I ask a cheeky question?
Yeah.
Please do.
You see, there's LFA, and then there's Thrive. There are a number of groups.
Yes.
Yeah.
Why can't you just have just one event? Because your population is not a big population.
Yes.
And I think Rihanna is just getting a maximum impact. Because Thrive have something at Kasarani, Kise Institute. It would be nice to have just one huge. I don't know, maybe. I've always been curious. Maybe let me ask for a question once.
Right, and you've gotten the platform. So, Faith, how would you like to answer that question?
Actually, we did meet up with the Thrive community to have one event. We felt the impact would be more if we are together rather than divided. Unfortunately for this year, they had already made steps for that particular day, and they would really like to uphold and not let down some of the vendors that they had already contacted. And we had already now also had a conversation with Aga Khan, who have been supporting us over the year. So for this year, we'll do it differently, but the conversation now from next year will be different. So we will make it happen. Yes. We'll come together for one major event, because at the end of the day, we are all lupus warriors, and our voices will be more heard or louder if we join hands rather than being separated.
I'm sure she'll share about the Lupus UK and how They do some very wonderful
job.
At
what point? This is the point. Don't go back.
We've talked about this several. The very first time I came to Kenya to do this project, I mentioned that we need unified patient groups because your patient voice is stronger. Yeah. So in Lupus, they have the Lupus UK, although they have smaller subgroups of the group within various other, what you call counties, potentially similar to counties, they usually come together as a unified group. And through that group, they have made so much change. They have financed research projects in the UK. They have supported their patients. So having one strong voice is really impactful. And that's something we hope that we can see in our Kenyan lupus patient groups, that unity eventually, just a unified voice. And even when we're doing the SHARP proposal, we did get the patient voice, but we had to get it from the different patient groups. So a unified voice would have been better, but we had to work with what we could get at that point in time. So I'm really glad that there are discussions about having a single event next year, because that would be very impactful.
Okay. There's a question that came through, and they were asking, how important is sleep when managing flare-ups? I lost my sister Carol a couple of years ago to lupus, and I would like to understand what sleep had to do with it. What sleep had to do with it. Is sleep important? Is it?
Yes, it is. Poor sleep can actually cause flares.
Poor sleep can cause flares?
Yes, it can. Yes, it can. And on top of that also, you can get another disease called fibromyalgia, which comes with sleep and pain. So the pain part is what is the problem. But see, the science of lupus and sleep is a bit complex. Some of the drugs, like the steroids, can interfere with sleep. The aches and pains can also interfere with sleep. And then also sleep alters some hormones in the body that interfere with what? With sleep. So we really push for rest. Rest. And actually, one way of rest is, also a challenge with sleep is that if I'm always tired, I'll sleep during the day, unless at night. So we really have to have some good habits of doing what? Sleeping. The fatigue may make them take more stimulants, the caffeine, teas, and everything interferes with what? With sleep. Fatigue causes, makes you not active in exercise. And research has shown that actually the thing that works for fatigue is actually exercise. If you exercise better, your sleep will be better. But now it becomes a challenge because you see, sleep, may sleep 4 hours and I'm okay. Another may 6 hours. You see, every person is what?
Different.
But we really encourage sleep.
We
really encourage rest. Not too much, but enough.
So the regular 8 hours. Okay. Let's take a question on WhatsApp so that we can have it answered before the break. Is there a relationship between, I think that is the one, we've answered that one. I think we've answered that one. Okay, good. Okay, Sawa. We've had Rosalind answer that. And so sometimes when I look at all the things that you need to do as a lupus warrior to take care of yourself, the one thing is you need to be constantly aware of where you're at, what your body is feeling. And, probably, journal it down at the beginning to just be able to understand the journey. But if, as we come to the end of this conversation, just to give an encouragement, to give hope to newly diagnosed people who probably have never gotten help, or probably they've gotten help and they're at some place where Naskiani come on and give up, there's no more money, there's nothing more that can be done. I'm just, sitting here a day at a time.
So I would advise them to take it actually a day at a time. And also to reassure them that it does get better. And also Doc mentioned and said that lupus is most common among the age group of childbearing. So the other thing that we really didn't discuss is that even many girls wonder, some of us, we're getting married, we are young, will I get to have children? Am I able to have children with lupus? And it's all possible. I am actually what do we call it? I am a witness or a testimony.
Testimony too.
Yes, I am a testimony of that. With the right guidance, with the right doctors, just walking the journey and being self-aware. And we also experience brain fog. So we say you write everything. Like if today you woke up and you felt your knuckles were cracking, write it down. If tomorrow you woke up and you felt you had nausea, you write it down. So that by the time you're going to see the doctor, you have captured everything. And then also them having all the information, they're now able to maybe say, now we need to do this for this, and you need this for this, so that you're able to have the right support and the right medication. And yes, it does get better. Is it difficult? Yes. But does it get better? It sure does. And also in our support groups, in terms of medication, because not everyone is able to access medication.
Yes.
So in our groups, we like people reaching out. When you don't have a certain type of medication, or you have a prescription and you can't access, people share what they don't have. Among ourselves, people also share medication. Among ourselves, we also have people who do small fundraising among their friends. And you'd get someone who would say, like, for my birthday, I got 130,000, and they donate it to the foundation. So that money we use it to pay for people fare to go, for those who have not had consultation for a while, for those who need medication, for tests. So we pin down people with most needs, and we say this one needs, send 7,000 there. This one needs, even medication. We have people who donate medication to us. Like someone will say, I have 100 packets of MMF, and I'd like to share. Yes.
I think that's really nice. And I know we have maybe 10, 20 seconds, Philip, is it? As Luke can get parting shots, 10 seconds each, please. So 10 and 10.
So it's not all doom and gloom.
Yes.
A lot has changed. We have better diagnostics, but more importantly, we have better knowledge of the disease.
Yes.
So our patients are living longer, and it's possible to give birth. I didn't touch much on childbearing and everything, but I think the take-home message is having an open conversation with your doctor. Sometimes when they come with the notebooks, it takes long in the consultation, but in the long run, it's less calls, oh, I'm like down like this. But you have a note conversation. There's lots of hope. Lots of hope, yes.
Your 10 seconds start now, Dr. Sheila.
I think mine is a call to government stakeholders. Yes. These conditions, you call them rare diseases, but they're very impactful at population level. We need to find ways to support our patients and offer them financial protection, give them the best care that they can possibly get. That's my parting shot.
Mark on 10 seconds. Thank you, Dr. Sheila. Thank you, Dr. Eugene. Thank you, Faith, so much for sharing, and continue being bold with your voice. Thank you for tuning in. And our WhatsApp audience, thank you for also sending in all those questions. I hope you got the doctor's number. You can reach out to them if you have further questions. To my crew, asanteni sana for making this happen. See you tomorrow, same time, same place. Adios.